Without further ado, let's start with our next session, which is genetic and environmental risk factors. Hopefully you've all had a great lunch. You ate lots of cake to give us a lot of sugar, a lot of energy for the afternoon session. We have a lot of great speakers with us. And I'd like to welcome, first of all, Professor Jessica Zuckman-Rossi from the Cordelier Research Center. And also President of the International Liver Cancer Association. A warm welcome.
Okay, thank you very much for your kind invitation. It's really a pleasure. The program is amazing. Thank you, Juan, and thank you to Anka. And I am sure that with the lunch, now you are ready to hear the liver, for sure. And hepatocellular carcinoma, it was like a preparation, a training during lunch. Okay, so hepatocellular carcinoma and liver cancer is the third cause per cancer worldwide. And I have to say, still the third cause per cancer. And you see that it is very heterogeneous worldwide because you have a high incidence of hepatocellular carcinoma in Asia and also in Africa compared to the other continent and other countries. But if we go more in detail on why we have this heterogeneity and geographical heterogeneity, the first cause of hepatocellular carcinoma is in fact hepatitis B infection. And you see, you see here that Hep B is very, very frequent. This is the incidence of hepatitis B infection, very frequent in Asia and also in Africa. And it's really mimicking the cartoon of the HCC incidence because more than 50% of hepatocellular carcinoma are still due to hepatitis B infection, whereas we have the vaccination that is developed since a long time now, and more at least 4 decades. The other risk factors are alcohol, and particularly in France, you know, once again it's heterogeneous, but here in France, 50% of the hepatocellular carcinoma are due to high alcohol intake, so this is our specialty. But we have also an increasing number of hepatocellular carcinoma due to obesity and what we call the MASH, that is a metabolic syndrome, and metabolic with alcohol or without alcohol. That means chronic liver disease that are due to obesity and metabolic syndrome. Okay, so that's the panorama, and you have understood, and all my talk is about hepatocellular carcinoma and liver cancer is really a disease of an environmental disease, and we have different environmental risk and exposure during life. We have very few in children, and fortunately only few tumors in the liver are developed in children. Some of them are related to genetic metabolic disease, but during life, more and more exposure to different toxic, aflatoxin B1, that is a true toxic of DNA, tobacco is also in the room, and obesity, diabetes, viral hepatitis B and C, but you know that the number of Hep C related HCC is decreasing a lot because of the very efficient treatment of Hep C, but still there. And alcohol intake and aging are really the most important risk factor of development of HCC. So these risk factors, this environmental exposure predispose to chronic liver disease and then to HCC. And during this process, we are used to say that we have an increased number of mutation and AP mutation. In my language, mutation is including AP mutation. And it's well demonstrated when you look at the tumor in children, only 2 to 4 mutations per tumor, driver mutation. But when you are looking at the number of mutation and oncogenic mutation in adult, it's much more important, 20 to 60 per tumor. And so it's really due to the accumulation of somatic mutation during life. So we will explore that together. And we have also to mention that 80% of the hepatocellular carcinoma are preventable, in fact, by this, if we can stop and fight these risk factors, we will have a decrease, expected decrease, at least by 80% of the number of hepatocellular carcinoma. But it is not happening. We are still eating, we are still drinking, and the Hep C and Hep B are still there. And the general process of carcinogenesis is that 80% of the hepatocellular carcinoma are developed in the ground of cirrhosis in the liver, and only 20% are not. They are developed in non-cirrhotic liver, and it is mostly the case of HBV, for example, that are frequently also developed in non-cirrhotic liver. That's the same also for MASH, and with more and more HCCs that are developed in non-cirrhotic. This is a problem because all the surveillance and the prevention of HCC and early diagnosis are based on the surveillance of cirrhotic patients. But if we have an increased number of HCC without cirrhosis, it is a problem also for the policy of early detection. So we will explore different topics. The first one is the role of germline predisposition, because it's in a section of genetics. And what happened, we know only very few syndromes that predispose to liver cancer, mostly in children, as I said, and very rare Mendelian metabolic disease. Most of these Mendelian predispositions are, in fact, dealing with metabolism. And you know that the liver is very important for the metabolism and the detoxification of the toxic. And there is only very few HCCs that are related to syndrome predisposing to other type of cancer. But what we know also is, so monogenic predisposition is very rare, but we have more and more results going into the polygenic predisposition and polymorphism. And this is the example of the polymorphism in these genes, TMCSF2, PNPLS3, and etc., that are predisposing to HCC in the context of high alcohol intake. So the people that are under surveillance for alcoholic liver disease, and these genes are predisposing or protecting for the risk of hepatocellular carcinoma. So this is a good thing, but also what we know, it's only in this polymorphism that account for an increase in odd ratios, that is, the risk is slightly increased. But we know also that they are playing with the exposure, as I said, with alcohol intake, for example, and there is some polymorphisms that are contributing and cooperating with alcohol only, but other polymorphisms are also cooperating with all the risk factors. So this is an American study, and you see for the different important polymorphisms that they can cooperate with alcohol, with diabetes, but also with cigarette smoking, and etc. So we are in a complex system, and in this system, for if I can simplify, for each risk factor, we have some genes that predispose in the germline, or that can contribute to predispose and to modulate the risk of development of HCC. Then we need to think how to translate that into the clinics. And so we can think to develop some polygenic score, and that could modify the program of surveillance, for example, or also we need to improve the evaluation of the familial and individual risk, because there is still some familial aggregation of HCC that are not very well explained. So the second topic now that is very new in terms of genetics is the role of clonal expansion in the normal liver. And what we know is that in all our organs, and the liver is not an exception, we know that we can develop inflammation in the liver, fibrosis also. And this is by this chronic liver disease that we develop cirrhosis, and the nodule in the cirrhosis. In fact, this is some aggregation of clonal expansion of cells with some mutation. And so it's what we term now mosaicism and somatic mosaicism in the non-tuber liver tissue here, like in other organs. We know also that during life, the length of the telomere, and particularly in the liver, is decreasing. And the bad news is that in the liver, this decrease in the length of the telomere, that are the repeat sequence at the extremity of each chromosome, the length of these telomeres that protect from the malignant transformation. In fact, they are accelerated by drinking, alcohol drinking, male gender, aging also. And this is independent risk factors also of the decreasing of the length of the telomere. And how the cells transformed in cancer. And in fact, it is because we reactivate the telomerase, and we need to reactivate telomerase to have a full malignant transformation. The major mechanism worldwide to reactivate telomerase is the insertion of the virus, hepatitis B virus, in the locus of telomerase, here. And you see that 50% of the hepatocellular carcinoma that are developed in association with HBV infection, in fact, they show an integration of the virus in the telomerase promoter. And this is very important because it's the explanation why these patients are developing HCC before cirrhosis. And these integrations are occurring in the liver very early during life. And it is also pleading for elimination early during life, the viral infection, in particular for also now HBV. There is also other mosaicism, and it is coming from the Sanger Institute and the work of Peter Campbell. And there is plenty of mosaicism and different mutations in FOXO1 gene, CBED, GPAM, that are occurring during the life and the chronic liver disease before the malignant transformation. And that is probably the adaptation of the liver during diabetes, during the chronic liver disease. And we need to better understand what is the role in malignant transformation. So the clinical impact of that is to use, for example, the TERT promoter mutation or insertion in TERT and TERT activation for the diagnosis and the prognosis of benign nodule in transformation in full cancer. And the second thing is how to evaluate the mosaicism and the risk of liver cancer according to the level of mosaicism. And this is some projects that are ongoing and that are very important for the future and for the surveillance of the patient. Another thing is that the toxic exposure is playing also with other risk factors, as I mentioned, but it is also the way by which now with sequencing, we can use this toxic exposure to have the history of the exposure to different toxic during the life of the patient. So just as an example, it's well known since a long time that aflatoxin B1, that is this very toxic molecule that bind to the DNA that are produced in the cereal that are not well preserved, particularly in Asia and humid and hot countries. And when you eat this cereal chronically, if it is eating alone, your risk of HCC is not very high, more high than the general population. It's comparable to the general population, almost. But when you are infected by HBV, then there is a cooperation, and you have a risk that is 100-fold more important than HBV compared to the general population. And so aflatoxin B1, in fact, deposits some mutation in the DNA. And when we sequence the tumor, we know very well how to identify these tumors that are due to aflatoxin B1 exposure. And we can also make like archaeology for some patients. Here it's a patient that was born in Mali, exposed in for aflatoxin B1. And then you see that the large number of clonal mutations are due to aflatoxin B1. But then he moved to France, and then the signature of aflatoxin B1 is diluted by other signature. And the signature 16, for example, is due to alcohol. So, welcome in France. Okay. And but we can recompose it and trace, in fact, the history of exposure. And this is very important because the liver is really a very good target to identify this signature, to identify other toxics that we don't know at this moment and that remain to be identified. And HBV, for example, also can translocate and alter the chromosome, so it is per se also an accelerator of the carcinogenesis, and it can induce an acceleration of activation of oncogene or inactivation of tumor suppressor gene. And as I said, more insertion of HBV in the tumor, worse is the prognosis. So it's also very important for the prognosis after the diagnosis that when you have a long history of insertion of HBV during the chronic liver disease, it's not good also for the prognosis of the tumor. So we need to prevent the toxic exposure during life, for sure, limit the HBV insertion, vaccination, and antiviral therapy early during life, and identification of new toxic exposure is very important, and we have the tool to do that. The last topic is tumor progression. I will be very fast. We know a lot of oncogene and tumor suppressor gene. It's a very complex also process to understand the mechanism of tumorigenesis. And once again, if you look at the hepatitis B, so we have 6 favorite subtypes. And if we look at HBV, they define the very homogeneous subtypes that are highly proliferative tumor, with some of them that are with stem cell activation of genes that are also very important for the chromatin remodeling, and etc. So risk factors are related also to the molecular subtype of HEC. So nobody is really using this classification, whereas we can decipher some targets and that are very useful to use some very specific inhibitors. But to do that, we have some program in France, for example, through France Médecine Génomique program, where we can include the patients with resistant treatment. They will benefit from the whole genome sequencing, and then we can have a molecular tumor board to decide for which treatments the patient could benefit according to the type of mutation that is found into the liver. And we have demonstrated that this strategy is working. It is hard to implement, but it is working, and the patient benefit and increase their survival according to this strategy and inclusion. So the clinical impact is really that the molecular tumor board for molecular-based therapy is efficient, but remain to be implemented in a more large scale. Translation into imaging will be very important because biopsy of the liver is also very difficult to do and the tumor is difficult to do for the patients. And in the future, transferring into a circulating biomarker is also mandatory and will be performed very soon. So this is my conclusion. We need to improve prevention, diagnosis, and treatment for hepatocellular carcinoma. Integration of the data from the different countries, it is really mandatory because you have seen the heterogeneity according to the different continents, according to the different heterogeneity in risk factor. But this is absolutely mandatory to better understanding the complexity of liver pathogenesis, and then to have some treatment and surveillance and diagnosis that are adapted to this complexity. Thank you very much.
Professor Zucman-Rossi, thank you very much. If I understood, if you're visiting Paris like me, tonight in the brasserie, just a glass of sparkling water tonight. Thank you very much. I'd like now to turn our attention to Canada, the University of Toronto, Dr. Stephen Gallinger, HPV Surgical Oncology Program, University Health Network. Thank you very much.
Thank you. Back to the pancreas after lunch. It makes as much sense as the liver. Your insulin levels are hopefully didn't overshoot and you're still awake and your blood sugar is not too low. I'm trying to cover a lot and I have too many slides, so one good disclaimer I have is much of it's been covered, so I can just sort of highlight on some of the ideas that have been really covered nicely this morning. The other, as an apology, I'm very much still a reductionist, and you just heard a reductionist approach to molecular tumor boards, and as a practicing clinician, or I was recently practicing, I just retired, clinicians are still taking a very reductionist approach. And I'll focus a little bit on how we've been doing this in pancreas cancer, mostly through molecular subtyping. I'm not going to talk too much about evolution. I think it's fairly obvious now. This disease is different, even though we have this precursor called a pannin. Transformation from a pannin to an invasive cancer is still very mysterious. I love the idea of the RAS, what you call it, rastopathy, because everybody in this room has a RAS mutation in their pancreas. So there is a rastopathy in all of us, but we don't really know what happens after this. It's a bit funny to think about since the 90s. We now know still the 4 genes, not much has changed. This progression model is a very old slide, and none of us now think it's as simple as this. And this was what I got interested in as a young surgeon in the late 80s. I thought Bert Vogelstein and Eric Ferron were doing some fantastic work showing this progression from adenoma to carcinoma in the colon that occurs over 15 or 20 years, and we assumed this would be the same with everything, but it's not the case. We showed with whole genome sequencing as part of the ICGC a long time ago that the instability seems to occur in pulses during a couple of cell cycles. Now, why that happens or how that happens is still pretty mysterious, but this whole phenomenon of chromothripsis, which is not just in the pancreas, it's in ovary cancer, esophageal cancer, and others, is still the mysterious cause of genomic instability and probably why this disease is so lethal. So it's not really a stepwise progression, it's very much a rapid progression. And as a clinician, I was doing surgery for 30 years, frustratingly seeing this problem over and over again. So when we kind of showed this at the molecular perspective with the scientists that I was working with, we got pretty excited because we were now finally on the same page. And that was this paper that Fayez published when he was doing his postdoc with us at the OICR. Now, since then, we've used a lot of the technology of whole genome sequencing, more from a discovery perspective. I'm not going to claim that it's a screening tool as yet, and we heard a little bit about it this morning. But using tumor-informed plasma whole genome sequencing, here's a pretty scary case that Fayez just showed me recently. A plasma sample was taken before the Whipple, a week before, and then the patient 2 years later had a lung metastasis, and on our COMPASS trial, we were able to get a biopsy. 4 years later, had a liver metastasis, and we have blood samples. We have the tumor in the pancreas, and we have a blood sample a week before the Whipple, and same time as a liver biopsy 4 years later. And using tumor-informed whole genome sequencing, we can see subclones that are in the liver, the lung, and the pancreas, and looking at the overlap. The pancreas and liver have a lot of the shared mutations, but remember the lung was in between. And what's really particularly interesting is that the mutations, the subclones that we found in the lung and the liver were in the plasma when the patient had their surgery. Now, most surgeons would say, well, that doesn't surprise me, but this is a good demonstration of just how scary this problem is, that the mutations that subsequently showed up 4 years later were in the plasma before the Whipple operation, which was supposedly a curative intent operation. You can see them there. So 2 separate clones in the pancreas seeded the lung and the liver. It must have occurred early, prior to the surgery. And we can see this now prior to surgery. This is interesting scientifically how it impacts the patient. I guess time will tell. Klaus can tell us in a couple of years. What does this all mean for the potential of early screening and MRD and treatment? So years ago, we started the COMPASS trial because we had done sequencing on resectable disease. We then wanted to apply it to advanced disease, which is 80% of the disease. It wasn't so easy. Now it sounds fairly straightforward, but we had never whole genome sequenced a liver biopsy. And what was more daunting is that we wanted to provide the result to the patient at 8 weeks when they had their first CT scan. The chemotherapy was chosen by the medical oncologist based on usual criteria, wasn't randomized. With all that, we've generated about 500 genomes, and it's, despite what you said about genomes, not that informative. Genomes are still somewhat informative. There are signatures in the genome. You just saw them in hepatomas. On the far right is homologous repair deficiency signature, which is the same in prostate, breast, ovary, and pancreas. This is signature 3. This is important because this actually directs a platinum-based therapy and now PARP inhibitor therapy. So these are important subtypes. There's only a couple that are clinically relevant, but they're pretty relevant. This one's in about 5 to 15% of pancreas cancer, depending on which population you're looking at. Some of them are in the germline. You can see the BRCA2 feature is really interesting. And this is just an example of an acinar cell carcinoma, another subtype of pancreas cancer. About half of those patients have a germline BRCA2 mutation. And look at the size of that tumor. I don't know if I have an arrow here. There's no arrow. There is an arrow? In the middle. Ah, thank you. This is the pancreas cancer, a massive tumor in the body and tail. And this patient has a germline mutation. And look at the response to FOLFIRINOX. It shrunk down by about 90%. This patient had a resection. So even though it's a bad disease, there is still a lot of heterogeneity in areas that you should be thinking about today as a clinician. Mismatch repair deficiency, which is much more common in colon and endometrial cancer and others, still occurs in about 1 in 200 pancreas cancers, and these respond to immunotherapy. And these genomes are very different. I mean, just look at the number of mutations in these genomes compared to the other so-called regular genomes. We're talking 30 to 40,000 mutations or a single nucleotide variants compared to about 4,000 or 5,000. So again, we have to find these patients. But as was mentioned, for sure, genomic subtyping doesn't explain the heterogeneity of this disease, and a lot of excitement over the past few years was based on the transcriptome, and giving credit to Moffitt and Collison. I went quickly through that slide. We have the basal and classical subtype, and our group actually has been using that a lot in our clinical trials. And just in that COMPASS trial, which is more of a registry than a trial, we showed that responses to chemotherapy, in particular FOLFIRINOX, did not occur in the basal subtype. And at the time, at least 4 or 5 years ago, a lot of oncologists were giving their patients FOLFIRINOX as preference. It's the so-called better, stronger chemo. And if you're a dying patient, you want the better, stronger chemo. But in fact, this chemotherapy doesn't work that well in the basal subtype of pancreas cancer. Naturally, it's hard to do an RNA sequencing in the average community hospital, so we've all been looking for surrogate biomarkers. One of them happens to be this GATA6 transcription factor, and using immunohistochemistry or in situ hybridization, which isn't that easy, but certainly easier than RNA sequencing, it's a decent surrogate for the basal subtype. And you can get this result even on an endoscopic ultrasound guided biopsy. So we actually published just the feasibility of COMPASS because the first 60 patients surprised us, and then we finished the trial, and you'll see the paper coming out in Nature Communication. And this is all 250 patients on COMPASS. These are patients whose medical oncologist chose their chemotherapy. We generated genome transcriptome in 8 weeks. We tried to alter the therapy at 8 weeks if it mattered. We didn't do that very often, which comes back to a point I'm going to make in a minute. And these were the final markers or biomarkers of how the patients did. Obviously, ECOG performance, or whether they received chemotherapy or not. Some patients never got chemotherapy. Even though we registered them at 2 or 3 weeks, they were too sick and never even got the chemotherapy. Moffitt subtype, basal classical, and then a couple of others like the GRIM score, which is an inflammation score. Another novel observation that we've made, and this will be in this paper, is that the basal subtype seems to have a little more of an immune-activated stroma, which is interesting. And also, when you start thinking about the RAS inhibitors, they also may have more effect in the basal subtype. Others have been finding this as well. Time will tell with all the new RAS inhibitor trials that we're doing. So these are some of the important questions in those first two concepts. What triggers invasion? Too complicated to talk about today. How soon does metastasis occur after invasion? Is targeting KRAS the answer? I guess we'll know fairly soon. How do we target these transcriptional phenotypes other than just ignoring chemotherapy or avoiding it? Avoiding chemotherapy is not what patients really want to hear, even though that may be the best option if you have the bad subtype. And then, of course, we're doing plasma whole genome sequencing, and you heard of many other liquid biopsy techniques. So interestingly, after the COMPASS trial, it became quite obvious, or it has always been obvious, that these two chemotherapy cocktails that we give patients had never been tested head-to-head. For those who know the field, will know that each were tested separately in different types of patients. A lot of bias went into the trials, not the trials, but the interpretations, and how medical oncologists were actually treating patients. So we were able to secure funding from Lustgarten and our own group in Ontario, and I can't remember the third, Canadian Cancer Society, to do actually a randomized trial of the two cocktails with a lot of correlates attached. So we actually randomized 140 patients to FOLFIRINOX or Gem/Abraxane, and we've been doing all these correlatives over here. I'm not going to talk about any of them today. They're all in the midst of being done. There should be papers next few years. And the result of the trial is actually quite interesting. We showed it at ASCO last year. and there'll be a paper hopefully in JCO soon. Patients are randomized to the two chemotherapy arms, and the results are interesting. They're really disappointing. These are patients who did not have homologous repair deficiency. They were excluded. These were patients at all the major cancer centers with a decent performance status, but realistically, some of the best patients probably went into trials at those centers, and the other ones went into this particular trial. But if you look at the outcome, 5 months, 4 months, first-line chemotherapy, no difference. In fact, FOLFIRINOX looks a little worse. So these are results, the first results from the PASS-1 trial, and confirms the basal subtype. Patients with the basal subtype had a 2.7-month overall survival, and these are in major cancer centers in Canada and the US. We have a really long way to go. Just finally, I'm going to talk a little bit about early detection. This is a 1 centimeter tumor. I am a surgeon, or was a surgeon, so I like showing surgical pictures. This is what it looks like. And the question is, should we give chemotherapy before or after? John Neoptolemus is going to talk about it, so I won't go into detail. We're all waiting on a couple of big randomized trials of giving chemotherapy before or after or both. We did a small trial in Canada that we just finished. It was presented last week or 2 weeks ago at ASCO. Very simply, we gave FOLFIRINOX before chemotherapy for patients with resectable disease. And we were analyzing the GATA6 basal classical biomarker post hoc as one of our endpoints. In Canada, there are restrictions on use of chemotherapy until there's evidence provided. So actually, you can't give or should not be giving neoadjuvant chemotherapy for resectable disease. No, I'm not talking about borderline disease. And here are a couple of the results. I won't go into all the details, but essentially, here's the 1-year events-free survival using GATA6 expression. Again, it's a retrospective analysis, but this is median follow-up at 26 months. The 6-month events-free survival for resectable disease was 90% in GATA6 high, so these are the classicals, and 57% in GATA6 low. So these are patients with resectable disease who had neoadjuvant therapy, who have the basal subtype. They did pretty bad, actually, with FOLFIRINOX given before surgery. What's also interesting, for all of the patients who responded, we didn't do a fantastic pathology review. We need to find a pathologist who has the time to look at the chemo. Every time we ask them, they go, yeah, one day we'll look at it. This is the way they were reported in terms of a response, or at least probably these were radiologic reports. The GATA6 low tumors did not respond, at least using RECIST or whatever pathology we had on the resections. The GATA6 high were the few responders that we saw. So this is the bottom line. Again, I just keep saying the same thing over and over again. For the basal subtype, we need better chemotherapy, and wonder if we should be giving them any of the two current chemotherapies. I'll just finish with a minute, last minute 12, that, where are we with survival? I have my own personal bias. I've been trying to do screening pancreas cancer for years. We did a small study in where I used to work at Mount Sinai. We took 250 patients, did the back of the napkin calculation. They were all BRCA1/2 or familial pancreas cancer. We said we'll find 5 tumors in 5 years if we do yearly MRI, I think, or ultrasound, whatever we were doing. And we found 5 cancers, and they all died. All patients died. They were either interval cancers or advanced disease. So I got really skeptical. We then did another study where we took the worst of those 250 using the PancPro screening algorithm to pick the worst cases. We screened those 50 people for 5 years, found no cancers. So again, we're pretty lost in terms of penetrance. What was even worse is that 2 or 3 of the patients that we excluded in the second study got cancer, and they were not being screened. So you can imagine how we felt about that. So with all that in mind, I became very skeptical. Then came George over there and a bunch of others who said, well, Steve, don't be so skeptical. We should keep trying. So we're still trying. And the way we're trying in Canada, or at least where we work, is we joined the PRECEDE trial, and George published this paper. This is a large international consortium run out of the US, but there are other centers. And basically, we're doing 6 monthly endoscopic ultrasound alternating with MRI with a ton of blood tests for Klaus and others who want to do biomarker research. The event rate is still really, really low, so it's a pretty boring study, but it has to be done, so we're doing it. These are the kind of cases that we're recruiting. They have 4,600 cases on, so it's actually a terrific study with a lot of familial pancreas cancer. At our site, we're a little behind George. He's put on about 4 times as many, and these are the kind of cases we're getting. So I'll just finish here and thank you for the invitation. As most people were talking about large teams, we have a very large team. I just want to mention this to anybody who's actually in the field seeing patients, is I think you have to really, really push hard for germline and somatic testing, because it does make a difference even today. We have a clinic in Toronto every Thursday. Almost all the patients, in a couple of hours, new patients will be seen, and they'll all be offered tumor testing. Anyways, thanks for the invitation.
Thank you very much. Thank you very much for absolutely fascinating insights. So we could drill down into that for days, couldn't we? So much information to take in. Thank you so much. Let's add another layer now from Germany, from the Technical University of Munich and the German Cancer Research Center. Professor Dieter Sauer, welcome.
Yeah, thanks a lot for the kind introduction. Thanks for the invitation to this great meeting. I learned already a lot. Also, I'm quite deep in the field. So thanks especially to the pancreatic cancer speakers. We will now even move a bit more reductionistic than Steve already did, because we are mainly working with mice, and I hope I can convince you that this also makes sense in this disease. The basic question we ask is that we see pancreatic cancer is a very complex disease, a very complex ecosystem, many different cell types. We do not know very well how they interact and how they somehow support the tumor and how they block immune responses and therapy response. And it's also a very complex, it's also a very heterogeneous ecosystem. And that's shown, for example, here in this recent study based on spatial transcriptomics. It's the most heterogeneous tumor type. And that's not only due to the tumor cells, it's also due to stroma heterogeneity and immune heterogeneity. And Steve has very nicely shown. Let's see if, sorry, I'm pushing the wrong button. Steve has very nicely shown that this directly impacts on the patient, and heterogeneity and sub-tumor microenvironments are associated with worse prognosis. This is quite surprising because the main driver is KRAS in the pancreas, and so the genetic heterogeneity is not so strong. That's why we then went into this very reductionistic approach and modeled these mutations in the mouse, and we combined KRAS mutations with many different others, which we find in the pancreas. And to make a long story short, what we discovered is that the driving oncogene itself generates heterogeneity, because loss of certain tumor suppressor barriers enable RAS amplification, and then the higher the RAS dosage is, the more undifferentiated the tumors are, the more aggressive they are, the less the mice survive, but also the less the humans survive. I will show you that in a minute. And that also directly impacts on the tumor microenvironment and the immune response to the tumors, and also on drug sensitivity, and I will show you that in a minute. And that has been recently validated, this concept that RAS dosage plays an important role in pancreatic cancer by this very nice study from Aileen O'Reilly, and showing that there are almost 40% of the patients have this high RAS dosage. And we often do not see that very well in the human samples, first because we look at surgically resected tumors mainly, so we have a strong bias toward that because there we have material. And that's the main advantage in the mice. So we have end-stage tumors, we can look at whole tumor evolution in these. And we just needed 40 tumors to identify that VAS amplification is an important aspect. And here in this study, there are 2,000 patients. So I think that shows a bit the power of the mouse system. At that time, when we discovered it, it was bad news for the patient because VAS amplification was linked to worse prognosis, and no VAS inhibitors were there. But that has completely changed. Now we have all flavors. We have on- and off-state inhibitors, even pan-VAS inhibitors, which are tolerable, which many people didn't expect, and even PROTAC-based degraders. And many of them are in clinical trials, and now there are even more than in this review in 2024. One remarkable example is this pan-VAS inhibitor in second-line metastatic PDAC. Overall survival is more than 12 months here, and it has not reached the median overall survival. And if you look now as a comparison, which is of course an independent study, for standard of care chemotherapy in this setting, there's a median overall survival only 6 months. So it's almost a doubling of survival, which is really, really impressive. The question is now, of course, why are still some patients not responding well, dying early, and why are we not able to cure these patients in the end? And in order to analyze that, and the question is in the end response to RAS inhibition and resistance, because that clearly shows that there is resistance, primary resistance, but it seems that there's also acquired resistance, but that might be, and I found Steve's data very nice from these pre-existing clones, because we have a lot of evidence that this is really the case also in the mouse model. So in order to investigate that, we need a lot of data and many tumors, and that's what we did in the past. So we generated many cell lines from mouse tumors, but also from humans, and we profiled them. And you can see that it's in the end a continuum. So these are all the cells, these are about 1,000, and we have 2 branches of EMT, and here are the epithelial tumors, and here you can see the profiles, and we classified them then also to all the existing classifiers, and see in the end that there are maybe seven subtypes, which we see at the transcriptomics level. And we now profiled these cells across more than 400 drugs, and also we did it also with these new RAS inhibitors. And what was quite impressive is that we have a 1,000-fold difference in IC50 values across this cohort. So we have super sensitive cells, but we have also super resistant cells. And these cells are equal resistant as, for example, a PLCK-driven tumor or a BRAF-driven tumor, so a non-RAS mutant tumor. So we have primary resistance and we have super sensitive ones. And this is also linked then to different genotypes. So certain genotypes, or certain in our mouse models, but also in humans, certain molecular alterations provide sensitivity and resistance to that. In order to go even deeper, we generate a mouse model where we can inactivate the mutation, so we can cut it out in an established tumor, so we can make a knockout of the KRAS allele. And what we again observed that some of these tumors respond very well, so there are no tumor cells anymore there, but others do not respond well. That's here quantified. And this is now bulk, and we wanted to ask, is this now maybe clonal events? So are there subclones that are resistant and sensitive? And that's indeed the case. So we picked individual clones, and you can see, we see in the end the same variety as we see in the whole cohort with this 1,000-fold difference. We see that even within one tumor. So really an incredible heterogeneity. You can see that also here in this is now proliferation rate, dramatic differences in response. And that motivated us then to look at the clones, how do they look like on the genomic level. And that's now the copy number plot, because RAS is, pancreatic cancer is a copy number driven tumor mainly. And we see that there is a lot of difference. So every of these clones is in the end different. We see some of them have chromosome 15 amplification where MYC is localized, and these are the very highly proliferating cells that are especially therapy resistant. And what we also see, which is also very scary, is that we see whole genome duplication again and again. So this is a recurring event. So it's not linked to the phylogenetic tree in the end. It happens again and again, which shows that these tumors can generate a lot of heterogeneity and a lot of genetic diversity. And then we barcoded the individual clones with express barcodes so that we can read them out with single-cell RNA sequencing. And then we treated, in this case, these tumors with MRTX, which is a KRAS inhibitor, and then sampled over the days these cells. And what you can see then under therapy, one clone rapidly outperforms all others and outgrows. And even after 14 days, we have then 70% of one clone, which is totally resistant, which you already see at 3 days. The nice thing is now we can do by the single-cell sequencing, we can have a look at each of these clones, at the individual cells. And this resistant clone is here. And you can see now here is the treatment indicated, and you can see that there's a clear shift in under therapy of the cells. However, this clone that is completely resistant doesn't shift at all, so it doesn't respond to the therapy. And that opens now, of course, possibilities to look at what are the drivers of that and how we can target that better. So in the end, I think this clearly shows that there's a lot of pre-existing resistance, and that's what also Steve showed. And I think it explains a lot why do patients relapse so early, and it's not after 10 years or many, many years. And it's often also not therapy-induced resistance. And that means, in my opinion, that targeting alone the tumor cells is not enough. We need combinatorial therapies, and not only targeting the tumors, but also the environment, and we need the help of the immune system to get rid of these highly resistant clones. And there are, of course, many possibilities. I plotted them here. I think immune cells are really central because they are able to eradicate these tumors. The problem is a bit that we have many bottlenecks in pancreatic cancer. So we have an underrepresentation of these advanced and aggressive PDAC subtypes in our existing data set. There is a lack of immunocompetent models that robustly recapitulate these subtypes. We have a limited understanding of the drivers of these subtype states and communities, and of course we also have no therapies for them. And that we addressed in the last year, so we profiled human tumors, but also mouse tumors, and we identified several different tumor microenvironments. Some are T-cell rich, others are macrophage rich, neutrophil rich, and immune excluded. We see that this is also the case in our mouse cohort. We then generated a human and a mouse single-cell atlas of quite some patients. There's still a bias to surgically resected cases, which are, of course, have a better prognosis, less advanced disease, and so on. But we are trying to complement that, and I think it's a job of the whole community to really look at the more aggressive tumors and try to sample them and profile them so that we get a more comprehensive and also a view on these 80% of patients that are not surgically resectable. And we see very nicely that the mouse atlas recapitulates many features of the human, so that makes us quite happy. And then we can use now our mouse models to generate immunocompetent in vivo models by using the cell lines. And you can see how heterogeneous it is when we implant the cells. Some recruit a lot of macrophages in, no neutrophils, there are no T cells in. Others have a lot of neutrophils, no T cells, low macrophage count, and others have a lot of T cells. So a huge diversity, and that shows that we need specific therapies in the end. And with these tools now, we can, of course, now look at the tumor microenvironment. We can do genetic screens, functional screens. We can develop therapies and also look at the microenvironment and host factors. What drives now these different TMEs? It's again the tumor cell and the state of the tumor cell that we can clearly show that classically tumors have more neutrophils, whereas basals have more macrophages, and we profile them by secretomics, by also functional genetics, and we think that the classical tumors mainly recruit the neutrophils via CXCL5 and CXCL1. There we have also genetic knockout data. And these then induce dysfunction of T cells, whereas the mesenchymal tumors, they are more immunogenic and more immune infiltrated, as Steve already mentioned. They rely on PD-L1 signaling and MHC, and thereby block immune responses. And by using spatial transcriptomics data and spatial profiling sets, we are now able to also look deeper into the macrophages, and we see, for example, that the tumor here is infiltrated by very immunosuppressive macrophages, whereas the anti-tumor, the phagocytic macrophages are somehow excluded from this tumor, and thereby we can now try to manipulate that and reprogram it. And if we do that very simple by CSF1 knockout, then we see already an improvement of survival rates. We can do functional genetic screens very shortly. We did it in the T cell rich, and then we find antigen presentation, which is very much expected. But we can do that also in other models to identify these models. We can develop therapies that we did that we screened was amplified versus non-amplified tumors. We observed that a combination is very efficient, and that sensitizes the cells to immune checkpoint blockade. And that's by the reprogramming of the secretome, as you can see here. So this therapy makes basal tumors hot, whereas classicals, it makes it bad because they recruit even more macrophages and neutrophils into the tumor. So subtype-specific therapies is very important. And last but not least, we can also now barcode the tumor cells, and we can see what is the impact of the microenvironment. This is now a single cell data set where we do not see any contribution of subclones to the features of the cells. It's rather the environment, because these are the tumor cells in vitro in blue, and after implantation they differentiate in various lineages. So there are invasive tumors, cycling tumors, hypoxic ones, acina-like, and these gastrokine tumors, and we can also read out them then in spatial transcriptomics data sets. So we hope that thereby we can much better understand what's going on and identify better therapies. And with that, I want to finish. I think there is now hope, because VAS inhibitors open a window of opportunity. We have more time to treat the patients. Maybe they can then even be surgically resected. But we need combinations. We need to target the tumor microenvironment, the immune system, and also the host, in my opinion. With that, I want to finish. That's the team that did all the work, and I thank you for your attention. Thanks.
Thank you very much. And it's always great to see the teams behind the work as well. A lot of overlap and a lot of agreement. I saw Stephen nodding often during the presentation, so overlap. Do we have some burning questions from the audience? We're running a little bit late, but we have time for a couple of questions. Yes, some questions here.
Very short, congratulations, great talks. Maybe this is for Steve, because you put it on the slides, Steve, that's all. But I've been asking a question this for a long time. Maybe this is for you or for the entire audience. You have 480 patients with ATN mutations in that trial. Fantastic. Now, my question is, how we medical doctors do not capture anything earlier on ATM mutations carrying patients until they develop the tumor?
I'm not sure exactly what you're saying. You mean there's 480 patients in PRECEDE with ATM mutations, and what's the complaint?
No, because there are two types of, that's what I was going to ask. Yeah. There are two types of the ATM mutations that we get in pancreatic cancer. We have the germline ATM mutation, right? That when we have 10% of ATM mutations in our cohort of 500.
Yeah.
And those are germline.
Yeah.
and they come with pancreatic cancer or other cancers, and it always caught my attention as a med student why we do not find anything
I know.
symptomatic.
Well, I've been asking the same question. I think the original observation about ATM being a predisposition gene has been a little bit controversial. We don't see any genomic signatures in the cancers with 2 hits, even though ATM is called a DNA repair gene, or it is a DNA repair gene. So how it contributes to pancreas cancer, I think is not known. So when you ask why we can't see earlier tumors in ATM, I think it's the same for, I don't think it's anything special about ATM. That's my personal observation. I know that at Hopkins, they've worked hard to try to classify a lot of the variants of unknown significance, because there's a lot. ATM's a huge gene. There's people in this room with ATM variants, and of course they want to know. I don't think the risk is as high as some of the other familial genes, but I think it's a bit controversial, and people are trying to understand penetrance. I don't know, George, do you have any more to say about ATM, or is that enough?
I would say that the PRECEDE trial is biased in the sense that we're seeing all of these patients that are getting germline testing for breast cancer diagnosis. So we're having patients that are.
It's a good observation, because we're seeing a lot. You're right, because a lot of people are getting germline testing for other reasons, and it's a big gene, so you're going to find a lot of variants. I don't know. You agree, Anirban? Yeah.
You know, it's a great topic when the conversation takes off in lots of different directions.
Or when I don't know the answer.
Great, yeah. So watch this space. Watch this space for a future conference. The answer maybe is coming in a couple of years' time. We have another question here behind Dr. Raul as well.
Is to deter the question. We are now currently testing the KRAS inhibitor of Revolution Medicine. We observe a lot of cutaneous reaction, and it's not so easy. Everybody told us it's okay, you will see it's okay, but it's not so easy. And we have a talk with Henny speaking of the specificity of target. With the pan-KRAS inhibitor, probably you target all type of mutation, KRAS mutation. Would it be better to test an KRAS mutation and to adapt the treatment for one single mutation, D or V, and would be maybe less as well as efficient, but less toxic, maybe?
I think it's of course attractive to target really the mutation. However, we see as well, so we directly compared the MRTX, so the G12D inhibitor versus the pan-RAS inhibitor, and it's about 20% less efficient than the pan-RAS inhibitor. So we get more efficacy on the cost of toxicity, and I think that's in the end what we have to figure out in the clinic, what is really feasible. And maybe by combination therapies, it might be possible even to lower the dosage maybe, or to switch to mutation-specific inhibitors. But these are all open questions, and I think, but we know them already and we can address them now. So I think it's even before the therapies start, we can address many of these questions because we have the tools now.
We have one more question here. If it's very quick, we have just a minute.
Very, very, very quick question. I heard resectability, and I gathered you're referring to technical resectability. What about biological resectability? There's a wealth of genomic and transcriptomic data. Steve showed a slide where the patient had, subclones early on, 4 years beforehand, and then developed metastatic disease later on. Is there enough data there, do you think now, that using whatever AI modeling we have, we could define which are the patients that will benefit from resection? Not neoadjuvant therapy, because we have poor therapies, but maybe some patients won't benefit for resection until we treat them and sort of see what their evolution is.
Could that be a short answer? Could there be a short answer?
I'm sitting right beside George all the time, so we can just talk it out there. I think that I think everything should be done in the context of a well-designed trial. That's the short answer. So I see nothing wrong with the idea of telling a patient you should not have surgery, or a terrible-looking tumor, saying you're going to do well despite the appearance of this tumor, using subtyping, whatever it happens to be, as long as it's in the context of a trial. That's kind of my view.
Great. Thank you very much to our participants. Fascinating.